everyone. Welcome to session 20 of the SCTS Foundation Doctor Academy teaching program. I'm extremely honoured to be joined by Mr. Jason Ali, who's a Consultant Cardiac and Transplant Surgeon at the Royal Papworth Hospital in Cambridge. And tonight he'll be talking to us about the post-operative management of cardiac surgical patients. We're very grateful to him for taking time out of his busy schedule. Over to you, Mr. Ali.
So yes, I'm currently a locum consultant at Papworth Hospital, and this evening I put together some slides to talk about the post-operative management after cardiac surgery, which, as those of you who work in cardiac surgery will appreciate, it's a little bit different to managing patients after other surgical specialties. The two commonest operations that we perform are coronary artery bypass, grafting, and valve surgery. And the reason to show this is really just to consider the types of patients who we are dealing with, and that has implications when thinking about how these patients are managed in the post-operative period. So for patients undergoing coronary artery bypass grafting, these patients are typically patients who have have the risk factors for coronary artery disease: smoking, diabetes, hypertension, and obesity. And those risk factors come with them other comorbidity, such as peripheral atherosclerosis of other vasculature, including the cerebral vasculature. Some may have history of stroke or the like, and then you have peripheral vascular disease of the lower legs, but also the similar atherosclerotic burden can also affect the abdominal viscera. And so the sort of demographic of patients typically undergoing coronary artery bypass grafting predisposes them to experiencing or possessing other comorbidity before they arrive. And that has a bearing to some extent in the types of complications that may be encountered by these patients in the post-operative period. And similarly, when we think about valve surgery, in these cases, patients may or may not have some of those comorbidities that I've just mentioned, but having an idea of the physiology of what's been happening to the heart can give a sort of preemptive anticipation of the type of trouble the patient may run into in the post-operative period. So, for example, patients with severe aortic stenosis typically have a very hypertrophied left ventricle, which generates a substantial power to overcome the gradient that exists in the aortic valve. In the post-operative period, where we have removed that obstruction and replaced it with a bioprosthetic or mechanical valve which has a minimal gradient across it, can lead to patients experiencing quite significant hypertension in the early and immediate post-operative period, to the extent that these patients may need to be treated with drug therapy to control the blood pressure. And importantly, for example, in the context of aortic valve or aortic surgery, the sort of aortic suture line is at risk if patients experience substantial hypertension. In contrast, patients with mitral valve regurgitation, the other sort of commonest valve lesion, those patients, particularly if they begin to develop impaired left ventricular function, can actually find them running into trouble in the early post-operative period, because the ventricle, if we consider the left ventricle, a dilated left ventricle when we talk about the ejection fraction, is simply a kind of measurement of the estimated volume in systole and diastole. The issue, of course, is that a proportion of that volume is passing back into the left atrium through the regurgitative mitral valve, which usually offers very little resistance. Sometimes when you make the mitral valve competent again, actually these patients can run into trouble because their heart, the left ventricle can't cope with this new situation where actually it is contracting, but now it needs to, the only ejection that is possible is that through the aortic valve and depends on the afterload. And so the reason to highlight this is simply to say that knowing what operation a patient has had when assessing them plays an important part in a sort of understanding of the patient's background and the type of problems that they may run into. Because actually, in this early post-operative period, patients may run into all sorts of different troubles. And some of this can be anticipated by knowing about the pathology of the patient. So when going to assess these patients, the key piece of first information is what operation did they have, because that will give you an idea of the sort of physiological issue that they were facing in the preoperative period. The other aspect that is unique to cardiac surgery is cardiopulmonary bypass. And as I'm sure that everyone is well aware, the bypass circuit is a sort of interface between blood and or creates an interface between blood and artificial surfaces, and this requires full anticoagulation with therapeutic heparin in order to prevent activation of the coagulation cascade to the extent that it will lead to clots forming within the circuit. Having said that, though, there are of course important. There is still activation of some of the pathways that exist within the blood, and also there is inevitably there is contact between blood and the PVC of the tubing and of the cannulae, and this does lead to, for example, disruption to the function of platelets, and similarly, the process of either centrifugal or roller pump can also lead to injury to blood, and again activation of cascades that essentially form part of an inflammatory response pathway. And this again has bearing on the sort of perioperative management of the cardiac surgical patient. There are two key things that happen when we place patients on bypass. The first is that there is an element of hemodilution, and that is required to facilitate the having a sort of having that dilution facilitates the flow of blood through the body via the bypass circuit. And similarly, there is a volume of fluid in a typical cardiopulmonary bypass circuit. There is about 1.4 liters of crystalloid that is included within the circuit, and immediately upon placing a patient on bypass, there is that degree of hemodilution, and that sort of counterbalanced that additional volume by a vasodilatory effect that is often seen by patients on cardiopulmonary bypass due to the activation of those cascades that I was referring to. And as a result, there are significant fluid shifts within the body whilst on cardiopulmonary bypass. And what I've shown on the slide is that this is affected by several parameters, and hemodilution I've discussed, the flow dynamics of going from a pulsatile circuit to a semi-pulsatile or non-pulsatile cardiopulmonary bypass circuit, the inflammatory response that's activated upon interaction between the blood components and the non-self PVC surface of the cardiopulmonary bypass circuit. And also another important factor that has an impact here is the temperature, and it is commonplace for operations that are performed on cardiopulmonary bypass to be performed at slightly hypothermic temperatures. And it may be that there is a significant variability, but many surgeons will perform typical operations, standard operations, even slightly hypothermic, 32 degrees, 34 degrees. And then you have the more extreme procedures, such as performing open aortic anastomoses in aortic dissection or like, where patients may be cooled to 22 degrees. And this cooling and rewarming has an impact as well on the sort of hemodynamics, has an impact on the activation of this systemic inflammatory response, and also impact on vasomotor tone in terms of leading to vasodilation or vasoconstriction. The end result of this is that patients often end up with several liters of fluid that they didn't have when they entered the theatre, and that has implications in the post-operative period, and also generally for in the post-operative management of these patients. And similar to the changes, the sort of activation of the cascade and the fluid shifts, this is just to highlight that there are a number of cascades that are activated by the impact of cardiopulmonary bypass, both the direct exposure, as I've been alluding to, of blood components and the PVC of the circuit, and similarly the alteration in flow characteristics, where in many a time cardiopulmonary bypass is performed with non-pulsatile flow. And what you can see here is the sort of idea that there is a generalized activation of a variety of mediators that are found within blood, which often leads to vasodilation. And the result of that can be that you need excess fluid in order to maintain the circulation. And in the most severe of cases, you get a sort of what's called a vasoplegia syndrome, whereby patients require significant doses of vasopressor medicines, i.e. those drugs causing vasoconstriction, in order to try to gain control over the circulation, because the result of a reduction in total peripheral resistance is that in order to achieve a set pressure, you need to have a significant flow. And of course, there's a limit to how much cardiac output can be performed by the heart, particularly in the early post-operative period. So in summary, in some regards, the cardiopulmonary bypass is harmful to patients, and there is a variety of phenomena that result in be that vasoplegia, in the fluid shifts contributing to the development of myocardial edema. And it is also important to highlight that because of this, our goal as a cardiac surgeon is to try to perform the operation as expeditiously as possible in order to minimize the cross-clamp and bypass times, because we know that bypass in general is harmful. But equally, what we know through hundreds of thousands of patients undergoing cardiac surgical procedures every year is that cardiopulmonary bypass is safe. And it is, whilst we should aim to reduce the duration of it, it is a very safe modality that we use on a daily basis to perform these surgeries. So with that as a means of introduction, what I want to move on to now is to consider the types of common sort of major problems that occur in the post-operative period, and discuss some of the management of these and also some of their basis, and by introducing the consideration of the type of patient who may be undergoing surgery, and also the sort of novel features that are associated with cardiopulmonary bypass. It helps to sort of contextualize the patients and the problems that are encountered. And I think it is also well recognized that all patients undergoing cardiac surgery will usually go to intensive care units to be managed in the early post-operative period. And patients are typically kept asleep for several hours in order to make assessments and exclude some of these problems that I'm going to go on to discuss, which then affect the early post-operative recovery. And the first, and probably to some extent, a problem that is encountered by all patients to some extent, but obviously to a varying degree, is what's called low cardiac output syndrome. And I think that what this essentially relates to is inadequate cardiac output to supply the needs of the body. And at the moment in the early post-operative period, some of the needs of the surgeon of the body will be enhanced as a consequence of the patient undergoing quite an invasive procedure. And the net effect of this reduced cardiac output is essentially boils down to reduced oxygen delivery to the tissues, which eventually leads to organ dysfunction. And a lot of the early post-operative management on the intensive care unit in the early hours after surgery is essentially to deal with and preempt and manage low cardiac output syndrome. And what is recognized is that patients who have more severe cases of low cardiac output syndrome, it is associated with an enhanced morbidity and mortality following cardiac surgery. Thinking about the risk factors for low cardiac output syndrome, there's a lot of things to consider, but in essence, any patient is at risk. And if you see here the age over 65, slightly impaired left ventricular function, procedures performed on bypass, diabetes, you can see here that many of these factors, these sort of predictive factors, are common to patients undergoing cardiac surgery. And importantly, here you can see the issue of cardiopulmonary bypass duration. And as I've suggested to you just before, the aim is, of course, to minimize that, because we know that prolonged cardiopulmonary bypass is associated with increased risks of some of these problems. So what are the signs of low cardiac output syndrome? As I've alluded to, inadequate supply of tissue oxygen leads to can present in a variety of ways. And I think when looking at patients at the end of the bed, some of these factors are things that need to be assessed on blood gases or the like. But the simplest sort of assessment is simply by touching their arms or the lower legs to feel, does the patient feel warm or cool? Because if they feel warm, you can be generally reassured that there is probably adequate cardiac output. More subtle considerations, of course, for patients who are awake is confusion relating to reduced tissue oxygen delivery in the cerebral circulation. But other parameters that are monitored hourly and very aggressively in the early postoperative period include performance of arterial blood gases, and that's because many of the features, for example, the development of anacidosis, elevation of lactate, are features which are seen on those blood gases, and one of the main reasons why these are performed on an hourly basis in that early postoperative period. Similarly, the development of acidosis, elevation of lactate, and similarly, that's a measure, a marker of generalized reduced tissue oxygenation. And as the measurement of urine output is also a very good marker of end organ function correlating with cardiac output. If the patient is passing a good volume of urine, that is generally indicative of a satisfactory cardiac output. And so actually measuring the hourly urine output is really quite a sensitive measure of cardiac output generally. And these patients who generally are slightly fluid overloaded by the time they arrive in the intensive care unit, we would anticipate and hope to achieve urine output in excess of 100 mils an hour for the first sort of 12 to 24 hours. And anytime when you see the amount of urine output dropping, the first concern should be, do they have adequate cardiac output? So the management of patients who you're concerned are developing or have developed low cardiac output syndrome, which is a sort of manifestation of those symptoms and signs on the previous slide in a patient who appears to be having reduced cardiac output, requires an understanding of cardiac physiology. And to some extent, some of the next slides I'm going to show you are going back to physiology that you may have learned in medical school. And it is in some ways to highlight that actually managing these patients does require a reasonable understanding of cardiovascular physiology. And if in thinking about that, the physiology can aid your management of these patients. Much of the management of many of these patients can be done simply with an arterial line and a central venous line. But for more advanced patients who are requiring escalating therapy, you can consider to place a pulmonary arterial catheter, which allows you to make a measurement of and quantify cardiac output and systemic venous resistance. And those two values and the ability to take what's called a mixed venous gas, which is essentially a blood sample from the tip of the cannula, the catheter, which lies in the pulmonary artery, which essentially is said to represent the complete mixing of venous blood, because if you take it from the SVC line, it is not truly mixed venous, because focusing on the venous return from the upper limbs and the head and neck, whilst you're oblivious to return via the inferior vena cava. And so taking measurements from the PA catheter is a measurement of true whole body mixed venous saturation, which is a measure, again, which can also give you an indication to the delivery and consumption of oxygen. So this equation, the delivery of oxygen, ultimately defines, if you can remember this, not the actual equation, but the factors that contribute to it, that is how essentially how patients are managed in the early post-operative period. And the bottom line is that delivery of oxygen is what you need to achieve. What are the factors that affect delivery of oxygen? Cardiac output, hemoglobin, and arterial oxygen saturation. They're the sort of three key things that we need to consider. Arterial oxygen saturation, we can assume in a patient in the early post-operative period, they're ventilated on, if you need to escalate the FiO2 to achieve a good saturation, that should be achievable in all of these patients in view of the fact that they are being ventilated. So then we can narrow our concern to cardiac output and hemoglobin. When we think about cardiac output, it's essentially the amount of blood pumped by the ventricle per minute. And essentially you can remember that cardiac output equals heart rate times stroke volume. And so what I'm trying to demonstrate to you is a sort of understanding of the factors, thinking about the factors that you want to consider making changes to are based on your understanding of physiology. So heart rate is something that is manipulatable, particularly in the early postoperative period where patients will typically come out of theatre with temporary pacing wires. And so that is something that I'll consider in a moment. Stroke volume, on the other hand, in and of itself, is a parameter that can be affected by a variety of things. Some of these are mentioned in this slide here. There is obviously the key three, though, are preload, afterload, and contractility. So stroke volume is essentially the difference between end diastolic and end systolic volume, and good left ventricular function is represented by an ejection fraction, a proportion of blood being ejected of greater than, in the region of greater 60 to 65%. So what are these three variables I alluded to? Preload. Preload represents a measure of the amount of blood returning to the heart. Afterload is the resistance against which the heart needs to pump and is a measure of the strength of contraction that's needed in order to pump the blood out of the ventricle into the systemic circulation. And then you have myocardial contractility itself, and that's a measure of the ability of the myocardium to generate strength during contraction that allows for the ejection of blood. And so I'm kind of straying into a little bit of cardiac physiology, but I hope that's what I'm trying to demonstrate to you is that this knowledge is required in order to be able to best manage these patients. So when it comes to managing patients with low cardiac output syndrome, these are the variables that we need to consider in order to improve that delivery of oxygen to the peripheries, assuming that we have good oxygen saturations. The variables that we can manipulate according to the equations are hemoglobin, heart rate, and stroke volume by thinking about preload, afterload, and contractility. So if we take these in turn, hemoglobin then is probably the easiest one to make a change to. Of course, in order to deliver an adequate amount of oxygen, you need to have adequate hemoglobin, oxygen carrying capacity. And typically in the intensive care environment now, the sort of threshold for considering transfusing is a hemoglobin of less than 80. So if you find the situation where the patient has a reduced hemoglobin, it is very reasonable then to transfuse in order to optimize that oxygen carrying capacity. And that's the easiest thing to consider. Patients in the early post-operative period, as we've discussed, may have undergone some blood loss in theatre, may have, and we've discussed as well that they experience a significant degree of hemodilution. And so it is not uncommon, and around about 30% of patients who undergo cardiac surgery require a blood transfusion. Heart rate, again, is another parameter that is very easily manipulatable in the early post-operative period. The vast majority of patients who undergo cardiac surgery have temporary pacing wires placed, either atrial or ventricular or both. And this permits an opportunity in the early post-operative period to increase the heart rate. And so the optimum heart rate, somewhere between 90 and 100. So a patient who you see to have a lower heart rate, one of the easiest ways that you can make a change to the cardiac output is by increasing the heart rate using this pacing device. And the safety net of this pacing device is in patients who may be, for example, in heart block, allowing you to maintain a cardiac output. But you can also manipulate this in order to achieve a high, to increase cardiac output by increasing the heart rate. When it comes to considering preload, this is Starling's curve, which you may recall from medical school. And the bottom line here is that the recognition that the amount of stretch of the ventricle correlates with the degree of contraction that is subsequently occurring in order to eject the blood. The optimum central venous pressure that we aim for is in the region of 10 to 12. And oftentimes you will find patients who have reduced CVP. And so again, what I'm trying to present to you is that what you need to consider is try to optimize all of these parameters, optimize the hemoglobin, optimize the heart rate. If you find a patient with a CVP of 1, then actually the preload is very low. And the simplest way to manage this patient is to give them volume, increase the CVP, aim for this CVP of 10 to 12. There's very much a move, certainly at Papworth, to avoid the use of colloids, and this is now achieved with predominantly the fluid administrated is crystalline. But this also is a consideration to make for patients on the ward later on in their post-operative period. Patients who have low urine output, a measure of low cardiac output, if they have a central venous line, transducing the central venous pressure can be quite informative. If the patient has an elevated CVP, or if they have a low CVP, you'll be thinking about different courses of management. In this case, if we see a patient who has a low CVP, optimizing that preload will help to increase cardiac output. The result of this is that actually, because of the vasodilation, as I described, due to the systemic venous pressure drop as a consequence of bypass, it is very common that within the first 12 to 24 hours after cardiac surgery, that the patients end up, in addition to the volume load that they've had in theatre whilst on bypass, also being administered a good 1, 2, or even more sometimes liters of fluid, positive comparatively to their outputs, so that by the time the patients reach the ward, they are sometimes 4 or 5 kilos heavier than they are in the early post-op, than they were before they had surgery. And that is why all patients after cardiac surgery are started on diuretics. The aim of that is to over a period of a few days, is to offload all of that volume. And so on ward rounds in cardiac surgical wards, one of the key parameters that the person doing the ward round will be concerned with is thinking about what is the weight of the patient. And daily weights are important for us to be able to track that the patient is returning to their baseline weight. And if we see that they are not, then it may require us to escalate the diuretic therapy. And conversely, once a patient with a good left ventricle who is not on diuretics preoperatively re-achieves their baseline weight, and if you see that they don't have any residual peripheral edema, these diuretics can be discontinued as they have served their purpose. The aim of diuretic, the reason to start all patients on diuretics in the early post-operative period is to deal with this volume overload that essentially the patients find themselves with as a consequence of going on bypass, but also this early low cardiac output, because low cardiac output syndrome, because what we see is that the heart ends up inevitably being a little bit edematous at the end of the operation, and the sort of edematous myocardium is a little bit stiff and actually responds very well to preload. And that is the reason why optimizing preload is an important first step before escalating to more aggressive management strategies. And often keeping an eye on the CVP can be a marker of problems in the early post-operative period. So then we move on to afterload. And here I think it's important to highlight that the afterload is a consideration that sometimes this is one of the variables that can be measured by a pulmonary arterial catheter. And I think that one of the troubles that I suggested in patients who have aortic valve replacement for severe aortic stenosis may experience hypertension in the early postoperative period. And that hypertension is related to the strength of the myocardium. But the management of those patients who are very hypertensive in that early postoperative period is to reduce the afterload. And those patients, it may not be that the afterload is excessive, but we understand from what I've told you earlier, there is a reason why that patient may be hypertensive, and that's because the heart is very strong and having to deal with that gradient of the aortic valve and aortic stenosis. And so reducing SVR allows you to reduce the blood pressure. And so the drugs that are commonly used in that scenario include GTN and hydralazine. And so patients who you see to be hypertensive in the immediate early postoperative period in intensive care will be started on these sorts of drugs. Going forward, once awake, the patients can be transitioned to oral antihypertensives, and commonly the drugs early introduced will be things like calcium channel blockers and amlodipine commonly. And also you may consider early addition of beta blocker, depending on what other drugs the patient may be on. The alternative scenario is that of a low systemic vascular resistance, and commonly the reason for that may be a consequence of cardiopulmonary bypass, and as I suggested earlier on, patients who become a bit vasodilated relating to the activation of all of these inflammatory mediators. And patients who have that vasoplegia, you may find them to be very warm peripherally, and that's because they are very vasodilated. There may be an element of sepsis, particularly, for example, if patients are having surgery for endocarditis, stirring up the inflammatory milieu of the aortic valve or the mitral valve vegetation can similarly trigger a systemic inflammatory response. And so often these patients may have high cardiac output, but because the SVR is low, they're very vasodilated, the blood pressure is low, and the delivery of oxygen to the tissues is low. The way to overcome this scenario is using drugs which act to vasoconstrict. And the commonest drug that is used worldwide probably is noradrenaline, which has a predilection for acting on the beta 2 receptors, which are found, the alpha receptors, which are found within the vascular smooth muscle, leading to vasoconstriction. Second line is ADH, or vasopressin, which acts on their own receptors, which also cause a vasoconstriction of the vasculature. Then it comes to contractility. So contractility is a reference to the ability of the myocardium to generate adequate pressure to achieve the necessary output that is required for the circulation. And if the hemoglobin is optimal, the pacing is right, the CVP is adequate and optimized, and there still remains low cardiac output. The next level of consideration is to think about things that will impact upon contractility. In the simplest thing we can consider is optimizing the calcium level, because calcium has a positive inotropic effect. But going forward from that, we'll be thinking about introducing the inotropic medicines. In Papworth, our first line is dopamine, but in many other hospitals and institutions, it may be that you'll consider to go to start on adrenaline or even enoximone if there's an element of right heart failure. So these medicines are drugs which essentially act via the beta-1 receptors to lead to increased contractility through their positive inotropic effect. Again, the effect of introducing these drugs can be measured by quantifying the change in cardiac output using a pulmonary arterial catheter. If we see that there is inadequate contractility despite high doses of all of these medicines, and that everything else is optimized that we've been discussing so far, then the time comes to consider the possibility of requiring mechanical circulatory support. In its simplest form is the intra-aortic balloon pump. And you can see here that the sort of image in the middle essentially shows the sort of typical position and of an intra-aortic balloon pump, which is typically inserted retrogradely through the femoral artery, and is a sort of helium balloon that is inflated and deflated in conjunction with the pressure tracing or the ECG, such that it inflates just after the aortic valve closes in order to increase the diastolic pressure. Of course, that is when the myocardium is perfused. So it aims to increase the myocardial perfusion. And the balloon rapidly deflates just before contraction of the left ventricle. Then the result of that is to reduce the afterload by creating a sort of vacuum, a slightly negative pressure within the ascending aorta. The net effect is said to be that it improves the oxygen supply to the myocardium by virtue of improving myocardial blood supply, and also reduces the work of the left ventricle by reducing afterload. And this is a device that is commonly found within the cardiothoracic intensive care unit as the first line form of mechanical circulatory support. If this fails and you're in an institution which has transplantation or facility for ECMO, VA, veno-arterial ECMO, is sort of more definitive means of mechanical circulatory support, and patients can be supported on ECMO for a period whilst either for assessment for some other treatment such as transplantation, or to permit a period of recovery of the myocardium, which can then after that recovery you can then wean the patient from ECMO. So low cardiac output syndrome is a common scenario after cardiac surgery to a varying degree. And the management of the problem, or this constellation of problems, which often may manifest on the ITU or on the ward as a reduced urine output, can be managed in just remembering that equation for delivery of oxygen. Hemoglobin, cardiac output, they're the two key parameters. Optimizing those two things will allow optimal delivery of oxygen. And the means to achieve that we've discussed over the last period. And hopefully what I've shown you is that actually having a knowledge of cardiac physiology is essential to the management of these patients. So moving forward to another problem following cardiac surgery, which is bleeding. Recognized complication following cardiac surgery. And it is the re-exploration rate for theatre varies from this graph shows you the sort of percentage of re-exploration for bleeding in each of the different centres in the UK over that particular period. And you can see that the incidence of return to theatre varies from 6-7% down to sort of somewhere between 1 to 2%. So it's a common problem. Patients bleed following cardiac surgery for a variety of reasons. One, a sort of technical issue which may relate to something is missed, or once the patient warms up, some vessels which are not apparent during the surgery may open, may be related to significant hypertension in the early post-operative period. But another important factor to consider is coagulopathy, because patients on bypass for a long time see significant derangement within their coagulation, and even more so for those patients who undergo rewarming and cooling to deep hypothermia. Bleeding is bad. Return for theatre is bad. This is a small study that I performed some years ago at Papworth, and we matched patients who had returned to theatre for bleeding and those who had not returned to theatre for bleeding. And you can see here, the key thing here is that there is a significant reduction in immediate and late survival in patients who return to theatre for bleeding, highlighting that bleeding is bad. So patients bleed in part relating to coagulopathy. As I've alluded to, being on bypass is a problem, leads to activation of all of these factors relating to coagulation, hemodilution, platelets, and other parameters, other sort of the proteins of the cascade are consumed whilst on bypass. And again, think to the patients we're dealing with, patients who are having emergency or urgent surgery, or have often been recently loaded on dual antiplatelets and are continuing with antiplatelets, and which has an impact in that early postoperative period. If you encounter patients in the early postoperative period for bleeding, the easy thing to quantify is if there is a coagulopathy. And in its simplest, the first thing to consider is there inadequate reversal of the heparinization, and this can be measured using the ACT. General FBC and coagulation screen can also be performed to highlight if there are any specific elements of the cascade which are lacking that you can then transfuse accordingly. And similarly, in Papworth, we use ROTEM, or in other hospitals use TEG, which are more advanced measures of coagulation and can specifically highlight which aspects of the coagulation cascade are depleted. It may be that actually the coagulation cascade is normal, and all of these variables are normal, in which case, if there continues to be significant bleeding, the only solution really is then to consider return to theatre in order to reduce that morbidity and mortality that I showed you. The other factor to consider is the use of cell saver. Cell saver device, such as the one shown in the picture, is a means by which any blood that is draining through the drains can be centrifuged, washed, and then retransfused as a means of reducing the loss of hemoglobin. As we know from the earlier part of the discussion, optimizing hemoglobin is an important component of maintaining adequate cardiac output. So bleeding is bad and should be managed accordingly. If there's no coagulopathy but ongoing significant bleeding, don't hesitate to take the patient back to theatre, because that is what they need, and reducing blood transfusion, reducing the volume of blood loss are all parameters which are shown to have a positive impact on, or high blood transfusion, high blood loss has been shown to have an impact on long-term survival following surgery. Moving on to another problem, dysrhythmia. Dysrhythmias are not uncommon following cardiac surgery, and there are a variety of reasons for that. Kind of brief reminder of the physiology, that the sort of generation of the cardiac action potential is within the SA node, passing through the AV node into the bundle of His, two bundles and three bundles, no, sorry, and then to the Purkinje fibers. And what is important to consider is the position, particularly of the AV node in relation to the valves. So this is a sort of picture. It's difficult to conceive without thinking about it, but actually the tricuspid, mitral, and aortic valves are all quite intimately related, as you can see here. In some ways, the pulmonary valve is the odd one out, as it's not in a similar way interacting with the others. The AV node lies in this position, and the relevance of this comes to the fact that when performing valve surgeries, when placing sutures in the annuli of the aortic valve, the mitral valve, and particularly the tricuspid valve, there is a risk of injury to the AV node. In fact, so much so is the tricuspid valve particularly related to the AV node, is that if you see the annuloplasty rings for tricuspid surgery, they are incomplete. Whereas typically the mitral valve ring is a complete circle. What you see for the tricuspid valve is an incomplete circle. And the reason for that is that the space that you see in that is positioned at the point where you would typically find the AV node, because it is very intimately related to the tricuspid valve. And so that is the reason why tricuspid and mitral valve annuloplasty rings look different. And this is to try to minimize the risk of injuring the AV node. And in particular, tricuspid valve replacement is probably the procedure which has the highest incidence of tricuspid valve replacement, have the highest incidence of complete heart block. But fortunately, tricuspid valve replacement is actually quite a rare operation. So complete heart block is manifest by dissociation between atrial and ventricular contraction, as you can see on the ECG that we see here. It is also important to say that if someone in the immediate postoperative period is found to be in complete heart block, it is not necessarily the case that they will remain in complete heart block. And it may be that some of this is related to edema around the sutures, and you haven't kind of transected the sort of conduction tissue. And so typically what we will do to manage these patients is monitor them for the first 7 days. Usually the cardiologist will be reluctant to implant a permanent pacemaker into a patient post cardiac surgery until at least 7 days. And the reason for that is that there is recovery of the heart rhythm in a reasonable proportion of the patients. And a permanent pacemaker is not without its own complications. Although it may seem to be a very benign procedure, performed under local anesthetic, implanting this little device, actually there's quite a lot of complications associated with it. Not necessarily immediately, but in the long run. So the development of thrombi on the pacing leads, the fact sometimes the batteries will run out and need to be replaced, sometimes the leads fracture. And so actually there is not insignificant morbidity associated with permanent pacing system in the very long term. And so the cardiologists quite rightly are reluctant to implant permanent pacemakers within less than 7 days following surgery. And what we see is actually that a reasonable proportion actually do recover. But still, for example, after aortic valve replacement, the commonest valve procedure, in the region of about 3 to 4% of patients require a permanent pacemaker. It's slightly higher in patients undergoing TAVI. And the reason for that is thought to be the fact that they inflate a balloon to a very high pressure to implant this valve and to expand the valve. And it's thought that generating that substantial pressure is what compromises the annulus and disrupts the sort of conduction tissue following TAVI. So nevertheless, there is a proportion of patients undergoing cardiac surgery who require permanent pacemakers. So these patients are monitored, and at 7 days, if they remain in heart block, will be usually accepted by the cardiologist for implantation of a permanent pacing system. The commonest dysrhythmia experience following cardiac surgery is atrial fibrillation, fast AF. The incidence of this is very high. It happens to about a third of patients following cardiac surgery, so it's very common. It is thought for a variety of factors that may predispose, including edema and inflammation as a consequence of handling of the heart during the surgery, electrolyte shifts in view of the diuresis that we induce in all of our patients in that first few days, in addition to losing the volume of fluid that they've gained throughout the perioperative period. It also leads to a significant loss of electrolytes, which can then predispose to the dysrhythmia. And some patients are inherently predisposed to the development of AF patients who have slightly enlarged left atrium, higher age, and, for example, mitral regurgitation puts some pressure on the left atrium in particular, and which is thought to be where many of the foci for AF originate. Fast AF, patients who experience fast AF in ITU or the ward are managed in a very similar fashion, starting first considering the electrolytes. So electrolytes is the first thing, mainly potassium. Hypokalemia is a significant stimulus to the development of fast AF, and hypokalemia typically follows the use of loop diuretics and this sort of significant diuresis that results. In addition to considering potassium, also magnesium, optimizing the magnesium level is also an important electrolyte that can have an impact on the of maintaining sinus rhythm in this early postoperative period. If the electrolytes don't work and the patient remains in significant fast AF, then we need to move to medications. And the commonest medicine that may be started in this early postoperative period for fast AF is amiodarone as an anti-dysrhythmic agent. There was a lot of debate within the literature as to whether, following in the development of fast AF following cardiac surgery, whether the target should be rate control or rhythm control. There are many surgeons who feel that actually there's no point in trying to cardiovert them into sinus rhythm by giving anti-dysrhythmic medication, and actually focus should be on controlling the rate, and that inevitably within time the heart rate will just go back into sinus at some point. And so these surgeons may consider the use of things like digoxin or the like to reduce the heart rate. Whereas perhaps more commonly, I think, is sort of the feeling to try to re-achieve sinus rhythm. And for that, combinations of beta blockers and amiodarone are the sort of common go-to drugs for regaining sinus rhythm. If in the pursuit of rhythm control you don't achieve that with medicines alone, the next step then is DC cardioversion. And so patients will then be listed for DC cardioversion if there's been a failure to achieve sinus rhythm with amiodarone, let's say, and the patient can be listed for DC cardioversion, which is usually successful. The very important thing to remember is anticoagulation in these patients. Patients who you are pursuing rate control, or patients who are pursuing rhythm control but who remain in AF for more than 36 to 48 hours must be therapeutically anticoagulated to reduce the risk of stroke. So cardiac arrest then, next problem to discuss. So cardiac arrest is a occurrence that sometimes happens in patients post cardiac surgery. And I think what is recognized and needs to be recognized by patients managing these, by doctors managing these patients in the ward, is that this is not the usual patient who experiences a cardiac arrest. These patients, you are much more likely to be able to salvage than medical patients on the ward. And so ALS, the standard ALS, is inadequate to effectively manage these patients in the postoperative period. There is much evidence in the cardiac surgical population to show that internal massage is far superior to external massage, and that you are very much more likely to be able to salvage the cardiac arrest by opening the chest emergently as a means of achieving resuscitation. And that is because the type of problems that may be encountered. So significant bleeding that in the absence of a blocked drain, for example, or once the drains have been removed, leading to the existence of pericardial tamponade, which may manifest as a low cardiac output syndrome, a clinical diagnosis looking for signs, for example, pulsus paradoxus, elevated central venous pressure may direct you to this. But some patients, if it's not diagnosed, may arrest. Opening the chest, which immediately relieves the pressure within the pericardium, usually will deal with the problem and the heart will start beating straight away. Similarly, the evidence that shows that internal massage is superior to external massage guides the team to emergently opening the chest. And the recognition of this has led to the development of which is commonly called CALS, Cardiac Advanced Life Support, or Cardiac Surgical Unit Advanced Life Support. And there is an algorithm, depending on which of these three limbs that you find yourself in. If there's VT, VF, as long as you can achieve defibrillation within 1 minute, rather than doing any CPR, the priority, attach the defibs, shock 3 times. If it doesn't work, give amiodarone, plan to open the chest. If there's asystole or severe bradycardia, if the patient has wires, try to pace them. If they don't, use the defib pads to pace them. If that doesn't work, plan to open the chest. PEA, similarly, if there's no evidence that pacing is a problem, plan to open the chest. It is recognized that emergent opening of the chest leads to life being saved. And the CALS course, which I would highly recommend in anyone who's involved in managing patients in the post-cardiac surgical period, teaches you an algorithm on how to manage these cardiac arrests. I had a patient only 10 days ago who experienced a VF arrest immediately post-CABG, and luckily I was in the intensive care unit at the time. We opened the chest within a few minutes, massage, the patient came back, and he has done extremely well and will be going home probably tomorrow or the next day. So these patients, so it sounds dramatic, it looks dramatic, but opening the chest in the early post-operative period saves lives. Inevitably, without opening that person's chest, you would not have been able to achieve the adequacy of cardiac output by external massage in those patients, and he would have died. So in discussing these cardiac arrest scenarios, of course, you want to try to avoid getting to that stage. And like I alluded to, pericardial tamponade is another common problem following surgery, which in the most extreme will lead to the development of cardiac arrest. But clues to it: low cardiac output syndrome, but elevated central venous pressure, presence of pulses paradoxes, as I suggested, can lead to suspicion. If you are suspicious of this, on the cardiac intensive care units nowadays, there are always people around who can perform a FICE or some form of echocardiogram. If you see a significant pericardial collection, similarly, depending on the scenario, if it's a few days post-op, you may consider CT guided train. If it's immediate post-op, it may require a patient going back to theatre. But trying to preempt that cardiac arrest is obviously more important than the cardiac arrest developing. So what I've hoped to have done through this in this last hour really is to give you a demonstration that cardiac surgical patients can be complex to manage, but actually having an understanding of physiology is really important. And common issues that patients face following cardiac surgery boil down to low cardiac output syndrome. And what I've hopefully demonstrated to you, that if you can remember the delivery of oxygen equation, good oxygen saturations, hemoglobin, cardiac output, remembering the three things that are, or the heart rate and the three things that affect stroke volume, will allow you to manage that adequately. Bleeding and arrhythmia are other two common problems that are experienced and that you may face as juniors managing these surgical patients. And hopefully through this talk, I've been able to give you a sort of brief overview of the reasoning behind the management, and also give you a sort of understanding of a greater understanding of how these patients need to be managed in this post-operative period. Thank you for listening, and I'm very happy to take any questions.